we can see.
Thank you to Mehmet for the very kind invitation to participate this morning. Thank you to the organizing committee. It's a real privilege to present to this group on spine radiosurgery indications and techniques. So spine metastases, as you've been hearing, is a very important direction that we're going overall in the oncologic care of patients, because we know now that the systemic disease progression, rather than the spinal mets, typically determine the patient's overall life expectancy. So any intervention that we do that's effective and has a minimal global effect on the patient, not long recovery time before they can continue with their systemic therapy, are all extremely valuable and desired treatment options. So a multidisciplinary integrative therapies are essential. And now we're starting to move more to treating not just those patients that are symptomatic, but we're starting to think about the asymptomatic spine metastases patients, because patient prognosis is prolonged. And by interceding at the asymptomatic phase in many of these patients, we can prolong overall survival. What are the important treatment goals in terms of spine metastases? We want to preserve and restore ambulation, maintain bladder control, relieve pain, and all of that is essential in patient quality of life. So the 21st century has essentially ushered in the new era of addressing spine metastases. The first game changer, things that changed how we look at this problem, things that move the needle, if you will, was the study by Patchell, which is now over 20 years old, more than 2 decades old, where we learned that direct decompression by surgical resection in the treatment of the spinal cord compression improves overall patient survival and many other factors by doing surgery plus conventional radiation instead of just conventional radiation alone. Because until that point, we as surgeons were blocked out a lot of this management of spine tumor care. So what we learned based on this randomized control study is that patients retained their ambulation rate, regained their ambulation rate in those that weren't walking, their neurological exam improved, their survival improved, their analgesic use dropped, their corticosteroid use dropped, all of which contributed to superior outcomes, and the study was stopped early. So all of a sudden, we as neurosurgeons and as spine surgeons, orthopedic and neuro, we were on the forefront of managing these patients and involved in the early discussions and decisions. Sorry, my mouse seems to be quite touchy this morning. So fine, surgical limitations can achieve local tumor control, but it doesn't. I heard Chris talk about the fact that there are some more radio-resistant pathologies, and we concur. We've known this for a while in terms of the intracranial radiosurgery targets, with colorectal cancer brain metastases being much harder to control with radiosurgery than other tumors, including renal. But still, while surgery improves neurological recovery and stabilizes the spine, metastatic tumors are not resectable to cure. So we must not throw the baby out with the bathwater, saying that radiosurgery doesn't work with colorectal cancer. And Chris, I know that's not what you implied, but just to be mindful, because when people hear, oh, it doesn't work for that indication, the thinking is, oh, well, we shouldn't be doing it in that indication. But we must remember that conventional radiation works even less for those radio-resistant pathologies, and surgery doesn't give us very durable control, no matter what we do in this setting. So we have the second game changer, decompressive surgery, and followed by spine radiosurgery. And most of you in this room are quite familiar with spine radiosurgery. It is targeted radiation delivered in an accurate and conformal way. In this illustration, you see the tumor outlined in the pink line. You see the orange is the radiation targeted dose with a very steep fall-off dose adjacent to the spinal cord. So the analogy is it's like a glove fitting a hand. So it is very tight to the target, but drops off very quickly, and you can move the fingers or get objects away from it. The dose drops nearly 20% per millimeter. So, and in this manner, we can deliver more than twice the amount of radiation to the tumor that we can with conventional radiation. But again, as Chris alluded to, and as many of us that have been in the field a long time are very aware, it's a multidisciplinary treatment and it requires multidisciplinary approaches to make this safe and effective. Who do we treat with spine radiosurgery? Patients with pain or tumor progression. Both of those indications are very strongly controlled with spine radiosurgery. Those that have minimal to moderate spinal cord compromise, those that are previously irradiated. In conventional radiation, if you give 30 gray and 10 treatments, the next time the cord won't tolerate that much. So the next time with conventional treatment, you have to give less. If the first higher dose didn't work, conventional radiation isn't going to work as a second dose treatment. So these patients were getting a second dose treatment before spine radiosurgery came along, and then going nowhere and going to hospice because they could not ambulate and they do not have a high enough performance status to get further systemic therapy. So in some indirect way, this was life-limiting until we could do very targeted irradiation with radiosurgery. Those that have residual recurrence after surgical therapy, this is very much separation surgery paradigm. Those that we couldn't get at very easily to decompress, those that have very short life expectancy from their metastases, and those that have significant comorbidities that we can't get them to surgery. All of those indications you heard alluded to in the notes. Who do we not treat with spine radiosurgery? This is an important portion as well. Those that have rapidly progressive neurological deficit. I had, in my early days, treated a patient with multiple myeloma, a very targeted recurrence. However, even though this is extremely radiosensitive, the patient deteriorated before we were able to deliver the treatment, which we had ready within 4 days. But the patient, by the time we brought them down for treatment, had lost all power in his lower extremities and had to be taken for emergent surgery. So this is not the treatment for patients that are rapidly neurologically declining, nor is it the treatment for patients that have cord compression with bone or disc fragments. Obviously, radiation doesn't work on those indications. And those with no known tissue diagnosis for cancer also are not appropriate for this treatment, such as you don't want to irradiate a patient that has an infection. Moreover, those with overt spine instability, no amount of radiation will treat spine instability, and therefore we have to treat this in a multidisciplinary fashion. So we have to be mindful that just because we have a hammer, not everything is a nail in terms of this indication. This is an older slide that looks at series for local control with radiosurgical treatment, larger series, and you see that the control rate is anywhere shown here between 70 and 95 beyond %. So highly effective treatment. Not a lot of cancer treatments that we can tell patients. We can control your local problem at about 85 to 90% of the time. This is a huge change in terms of cancer discussions with patients. We can control your pain 85 to 90% of the time. And this slide gets at that. With spine radiosurgery, with their own prospective work, we found that as early as 1 week, we have statistically improved pain relief using the BPI pain score, and it's durable at 9 months out. And this can be with as little as treating a single vertebral level. We improve the patient's pain score globally. We improve things like their insomnia. We improve their constipation because they don't have opioids and therefore they don't have constipation. And we found that in these patients, their narcotic use dropped and their no pain medication rates increased. And overall, we had a durable quality of life for the patients in our series. Now, for those of you that haven't seen spine radiosurgery, this is a patient's journey. This is one of my patients that you see the therapists are putting him on the table, comes in. This is one of my radiation oncology partners who we've done an enormous amount of work together. My patient allowed us to take these images. He is being lined up. We have a mask to immobilize him because you can't target your target if it's moving. You can't effectively do submillimetric precision. The target is moving. We have open face mask because where there's facial recognition for our patients that are claustrophobic for the treatment, they lay down. You can see the marking of the mid-cervical spine where we are targeting this patient. He is lined up for treatment. He's very relaxed. He's comfortable. And at 5.5 minutes, he is coming off the table and going to lunch with his wife. I'm a surgeon. I love being in the OR, but there is no better outcome for a patient than to get off the table and go on to proceed with life and their families, especially when they're fighting so many battles with cancer globally. So this treatment is a very rewarding practice to be involved with, especially when the rates are effective to 85 to 90%. So what are the major potential benefits of radiosurgery? Short treatment time in an outpatient setting, no recovery time, good symptomatic response, positive impact on quality of life, successful tumor control, low morbidity, minimal risk of radiation myelopathy. The studies indicate that the rate of radiation myelopathy is less than 1%, 0.6 or 6 per thousand, essentially, and particularly relevant for tumors that are conventionally resistant to radiotherapy, such as melanoma, sarcoma, and renal carcinoma. Here's a case of a patient who had a C2 renal metastases. He developed severe neck pain with a lytic destruction of his C2 and a synchronous renal mass. The renal mass was biopsied and showed RCC, and one of my colleagues did posterior neck stabilization, but did not tackle the ventral disease. So he had persistent pathology ventrally. He underwent a treatment of radiosurgery, 18 gray, with a single fraction. And 2 years post-treatment, you can see in the bottom panel, the ENF panel, that he had significant spinal cord decompression. He continued asymptomatic for 2 years beyond. Actually, now he's 5 years. This is a much older slide. He had no further intervention at this level, and he's gone back to coaching small children playing soccer. So with this procedure, we have gotten two relatively minimally invasive approaches, or non-invasive radiosurgery has gotten him very durable control in contrast to a surgical procedure that could have been extremely morbid and not given us the same durable control. What was also alluded to was that dose matters. We want to get in as much dose as possible. The only problem is that unlike the lung or the kidney, where organelles are duplicated, so you can take out one kidney and have the patient's renal function still be essentially maintained, or you take out a segment of lung, you cannot disrupt the spinal cord. It is a serial functioning unit, and therefore radiation toxicity to the serial organ will cause major morbidity. And so the key to treatment safety is to get in that high dose, but carefully dose constraint the adjacent spinal cord. So enter the third game changer that was referred to as separation surgery. And I think most in this room are very familiar with separation surgery, but just to be totally clear, separation surgery is separation of the tumor from the dural sac, thereby decompressing the cord in order to reconstitute the spinal fluid space, the CSF. Tumor in the vertebral body and paraspinous region is not resected, reducing surgical time, reducing blood loss, and reducing morbidity. So our patients are not in the ICU for prolonged periods of time with limited prognosis. Decompression provides a safe margin. The purpose is to get that safe margin to deliver cytotoxic or ablative dose to the tumor within the constraints of what the spinal cord tolerates. If millimeters can be gained from back of tumor, front of spinal cord, that is huge because the vast majority of metastases occur in the vertebral body and often abut that region. Stabilization, of course, depends on the degree of instability, but most times it is 2 levels above and 2 levels below, and anterior reconstruction is rarely required. So we've moved the paradigm that surgery is an adjunct to the definitive oncologic procedure of radiosurgery. Separation surgery, some of this data was discussed, and I'll move on in the interest of time. Another study that we looked at in terms of fusion rates. We used to do surgery followed by conventional radiation, and I think that's the paradigm in many centers. what I might argue, even in this small series of 15 patients, we found that patients that underwent radiosurgery following surgery did better in terms of fusion rate and fewer instrument construct failures, breakdowns, screw breakage, etc., than those that had conventional radiation. So now the structure at risk is the construct. So if we do more targeted radiation and we don't try and we try and keep the dose off where the fusion is meant to be, in our patients that are surviving longer, we are able to not have to fix their instrumentation. We're not having to go 5 years alive from their having to fix their instruments, which have failed over time. And this study showed from Memorial's group that their hardware revision rate is very low and in a large series. So once we're starting to do that, the hardware pattern of failure after separation surgery and many times after radiosurgery is very durable. This has led us to a rapid expansion of the use of spine radiosurgery. So over the 15-year span that we looked at an international survey of 12 high-volume centers, we are seeing much more utilization across centers. And what we're seeing, if you look, for example, at the gray line, which is renal cell, we are seeing over these are 5-year increments, we are seeing many more classically radio-resistant pathologies being sent for radiosurgery. So this remains a very relevant use of radiosurgery over conventional radiation. Where are we going in the future? This is the more novel part, the more interesting, newer direction for radiosurgery. So oligometastatic disease is 5 or so metastases in patients that have a diagnosed cancer. So it is considered low volume metastases or low burden metastases. So classic approaches to oligometastatic disease are based on identification of patients with local or local regional group tumors or patients with distant metastases. So this has led to the hypothesis that if a cancer can be controlled using local ablative things like surgery, for example, in colon cancer when they're doing metastatectomies of the liver, when they're doing in sarcoma metastatectomies of the lung, can we, instead of surgery, use radiosurgery within that same approach to ablate low volume metastases? And this prospective study showed that indeed we can. It is a ablative radiosurgery across a number of targets, not just spine targets. And we found that patients that underwent radiosurgery to oligometastatic targets had significantly longer progression-free survival, local control, as well as overall disease control, overall survival. So we are starting to do much more oligometastatic disease. And what we're finding is if we look carefully, we find that not only do we kill the tumor in that area, but we are seeing new bone laydown. The fatty marrow replaces the previous osseous metastases. So we are getting reconstitution in certain aspects of the bone. It's not as good as native bone, but it's certainly stronger than tumor mush in these areas. So we are also improving, in one sense, the spine health of the patient by doing local control as well as their overall survival. So the current recommendation is that radiosurgery is safe and effective with durable symptomatic response and control. It should be considered over conventional radiation therapy for the treatment of spine tumors in oligometastatic disease and in radio-resistant histology. And as experience grows, the use of radiosurgery as a post-operative adjuvant surgical resection less aggressive, with the expectation that radiosurgery will help control or maintain the residual disease. But again, a reminder that was alluded to is that spine tumor programs are inherently collaborative, and this is essential for the program to succeed. We have a spine tumor board which really anchors our decision making. We meet weekly, we have multidisciplinary attendees, we have individual recommendations with an integrated plan. Many times it's before the patient has been seen. so that at the first clinical visit, we hear the integrated plan, we have a database. As you see, there is high surgery participation here, where the blue part of the pie is cases brought to tumor board from surgery, but not necessarily treated with surgery. And the COVID was one of the few positive things to COVID is this virtual visual conferencing, where during that time we saw a huge bump up in participation in spine tumor board. And at this time, we've reviewed over 7,500 cases at our spine tumor board to date. This pie chart shows the kind of cases that are brought. And one of the important things is you see about 20% are non-tumor, and we have 2 dedicated neuroradiologists that attend our spine tumor board. So we have a subset of our neuroradiologists that participate within this tumor board, and they help also define some of these cases that shouldn't be biopsied, shouldn't be managed, that they're non-tumor, there's some kind of inflammation, etc. So spine tumor board has really informed so much of what we do in these cases. So what does the future of SRS look like? It clearly demonstrates clinical value. It's non-invasive, can be completed in an outpatient setting. The patients from the rural setting or far from treatment centers come in and can get treated in one day. The minimal disruption to their systemic therapy, so they don't have to stop their chemotherapy for a month post-surgery. This allows patients to resume their normal activity as quickly as possible. It decreases medication, increases the need for retreatment because the control is more durable, so that there's huge advantages for society, for the healthcare system, and importantly for the patient. Why is this important? My patient, she allows me to take her picture. She's a retired manufacturer worker and a grandmother. She's diagnosed with stage 4 non-small cell lung cancer. Her neck hurt so badly that brushing her hair or flipping it off her face became unmanageable, so that she cut off her long hair. She underwent spine radiosurgery to C1, C2 with complete pain relief, and her tumor was controlled 4 years ago. Her hair is now back to waist length. She is pain-free, chases her grandson, and travels to watch her youngest daughter play college softball. These are our patients who deserve our best in terms of care. Remember the patient, and I'd like to thank this awesome team that I have the privilege of working with in terms of spine radiosurgery. Thank you for your attention. Happy to take any questions.
Thank you very much, Dr. Angelov, for your beautiful presentation, which is rising up also some question and consideration. Since radiosurgery interact both with radiobiology and mechanical factors inside the metastatic location, my question is, what's your experience about interaction between radiosurgery and embolization, vertebroplasty, and previous other procedure changing the local structure of the bone and of the tumor as well? So probably embolization and glue, the cement and vertebroplasty could interact negatively with radiosurgery. What happens when you deliver radiosurgery to those subjects?
So, in fact, there's no issue whatsoever. Patients can have bone augmentation with no difficulty in delivering the radiosurgery. We've done Monte Carlo calculations. If there is any change in dose, if there is any change related to the instrumentation, if there is any change related to the cement, there is no contraindication with that. Embolization, in terms of, just to get back at an earlier comment about pain relief, we have been a little bit underwhelmed in terms of pain relief with embolization. We use it for blood saving rather than pain amelioration. I have even used this in the setting of symptomatic hemangiomas that have epidural extension, and we sometimes try embolizing those because that's one of the forefront indications, and that doesn't give us good pain relief. The key, though, to radiosurgery is that the images that we treat on have to be in close proximity to when we deliver the treatment. So our treatment time between the fresh high definition MRI scan with no skips between slices for targeting radiosurgery and delivering the treatment is typically between, it can be as early as 4 days, it can be as long as 10 days, but I will not work off a stale MRI scan because the tumor is growing in the meantime. The tumor is changing. If you can't target your target well because it is moving or because it has changed in size, then you're not doing precision targeting. And unlike conventional radiation, which is forgiving in terms of size, this is not forgiving because there is such drop off in dose, so that it, in terms of precision targeting, it cannot be off an old target. But there is no contraindication. Protons and some of the standard screws and rods interact. Radiosurgery, because it is photons, we have done the calculations and the dosing within our physics department, and there is no contraindication. There used to be lots of fear when we started this. We started the program in 2006. We've done this a long time. We used to be very anxious about, are we getting the dose? Where, in terms of compression fractures, we see a compression fracture rate related to radiation. I agree, that's one of the side effects. I always tell my patients, yes, there is a compression fracture rate, let's say 10%, for example. If that's the biggest toxicity, if we can control cancer but take a 10% toxicity of compression fracture, we'll take it. We all have compression fractures as we shrink in height as we get older. So that part is, I will take that as a toxicity. If patients have lots of motion, we can do vertebral augmentation after radiosurgery with no negative impact. I always do get a biopsy, though, to make sure that the cells are dead.
Just a second and last question and clarification request. Is it possible to deliver adrotherapy with the same modalities of radiosurgery? Why not?
It just got muted. I'm sorry. You asked me, is it the same?
Is it possible to deliver adrotherapy with the same modality of radiosurgery? High doses, shorter time, and with the stereotactic modalities. Is it possible to drive this option with these typical characteristic of the technique you showed us in your beautiful presentation?
Typically, no. Sorry, the sound keeps coming in and out, but I think I got the question. The question is it possible to use standard machines to deliver precision therapy, to deliver radiosurgery? Is that correct?
Yes.
Okay, so no, the system has to be, it has to be a different system. The aperture for delivery, it has to be very different. And there is a number of machines that can do conventional radiation and radiosurgery, but it has to be specially able to do that. You can't, drive a truck on a Ferrari course.
Yeah, there are some questions in the chat.
Thank you.
There's some questions in the chat box. Can I ask them? Dr. Parekh has asked how many levels of metastasis you can give radiosurgery. What is the maximum number?
So thank you for the question. Actually, I'm excited to answer this question because we have a paper that is coming out very shortly. We have to be practical. This is local therapy, right? And so we want to treat local disease burden. If the patient has many, many, many levels, it's appropriate to do conventional treatment. But we have recently looked at, and so the short answer is usually 3 consecutive levels are appropriate, and it can be in 2 or 3 regions. We have recently looked at our control rate for larger tumors versus single level and found that the control rate is the same, so that radiobiology and control is not impacted by size.
So what I understand is 3 bodies, either adjacent or at separate level, you can give in one sitting.
You can give 3 times 2, right? C 3 to 6 and L2 and L5. They're treated as completely independent modalities, but 3 consecutive.
Okay.
Is the usual.
Thank you.
Is that your experience?
Yeah, I think something similar on our end, where we do essentially treat them as different isocenters, and so we'll do 3 or so consecutive bodies, and then think about cervical, thoracic. Like if there's a large gap, think of them as differently, and then we'll also kind of try to triage them based on what's symptomatic as well, right? And try to say something symptomatic, prioritize treating that over treating the asymptomatics, and prioritize the epidural disease treatment over the ones that don't have that. So yeah, a similar paradigm.
Does it make a difference in the outcome if you treat with MR LINAC or a CT-based LINAC radiosurgery?
It looks like not based on lung treatments. So I cannot tell you we do not use MR LINACs. But the targeting, we use the CT simulation and an MR. So we use both those data sources in order to target.
There's a question for Dr. Newman about any experience with RFA in oligometastasis along with separation surgery and outcome.
I'll say I don't have a lot of experience with that here, and I think that's really a byproduct of the fact that we have such a robust radiation oncology department. And I think that's really where we've been treating it. And because we have such good outcomes from that combination of like separation surgery followed by SBRT, we haven't gone as deep into the use of RFA. So I don't have a good answer for, we don't really use it, so I don't have a lot of experience in that area. And I don't know what the data would say in terms of the long-term benefit. And kind of the same way if I look at like the Saber Comet trial in terms of like the oligometastatic population, where you can see a benefit to the treatment of ablative dose radiation from the abscopal effect. I don't know what that looks like for the RFA population. It's a great question. I just don't know the answer.
So we do RFA at our center as therapy at recurrence. And again, because we have 3 interventional radiologists that participate in spine tumor board, and so they step up to get involved. They step up if there is sacral recurrence, etc. So but we don't have robust data on it. It is definitely doable. The problem with RFA is radiosurgery can give us this glove on a hand because we can specifically target. RFA is like a ball on a stick. You cannot change its shape extensively in order to fit your target of the vertebral body. So that one of my concerns about doing RFA up front when we have a different modality that can be precision targeted is not so much concern for the cord or things like that, but concern for ablating the entire tumor region. It may be good in the portion, but if it looks like a ball in your vertebral body, looks like a vertebral body, you're not covering a huge component of the active cancer cells in that area. That's my bias. We do use it. We do use it in failure when we are maximized, because when you have a therapy that controls 90% of tumors, that means 10% can fail. We use RF in those settings, but not as our first choice. Does that answer the question?
I think that same end, I would think about Claudio Tatsui's data kind of with their use of laser and interstitial thermal therapy for the spine, where when you look at it, he's really not using it as definitive treatment. He's using it as like adjunct to get to the next thing. So I think that's probably a great place to look for data in terms of the papers he's published on that.
Yes, agreed.
Thank you, Dr. Angelo and Dr. Newman. And though we have more questions, we'll take their surgery questions. We'll take it after the lecture by Dr. Corina on surgery, indications, and